Thank you for the kind invitation. First of all, I would just want to say that was really very impressive. All this efforts has been done over these years is really, really impressive. So it's an honor for me to be here after you to present my little experience about cardiac imaging and TAVI. I have two important points that I want to mention initially, that cardiac imaging has become an integral part of many interventions. But more importantly, that many of our interventional cardiologists are becoming experts in imaging. So they are challenging me every time I'm making some interpretation. They became more experts and they require more accurate assessment, and that's challenging me. So I hope that this goes to your expectation, but that's what I have. So TAVI has been there for probably now 20 years. In the last decade, most of the evidence has developed, and it was clear from the beginning that transcatheter intervention is not like surgical procedure where everything is seen and by eye and then they can control it. No, it has to be planned before, because it's going to be done blindly. So everything has to be done before that. So those are the 5 major complications that has been recognized in transcatheter aortic valve implantation. And all these years has been going to try to reduce these complications. I'll just share with you some of the evidence that has been there from the beginning, even from the starting of the Partenal trials, multiple Partenal trials, and has been shown that the paravalvular leak was more common than surgical. Of course, it's getting less and less now, but it is important, and even slight or moderate paravalvular leak can increase the mortality, so it's not something that trivial. The other complication that was also frequent, which it's good that we had go through a long improvement in the technique, the major vascular complication. And maybe everybody of us remember the early days where the sheath was big and the technique was not refined yet. There are a lot of major complications in the femoral arteries. And this is again from Partenal trial, and you can see that the major complication was up to 15%. The other complication that was important is the need for permanent pacemaker. And again, the permanent pacemaker still hanging there. Probably we need better improvement in the technique or the valve or the implantation depth. Multiple points that we have to see. So what is the critical point of cardiac imaging, especially cardiac CT, because I'm concentrating, is to have the accurate selection or better selection of patient for certain valves or certain, let's say, size of the valve or certain type of the valve, and also to have an accurate planning and measurement of all these parameters that require to improve the safety of the patients. So the goals of cardiac imaging in general is to have a better selection of patients and determine the suitability of the valves and the access. But what is more important is in the right side of the slide, where to ensure the safety, because that's the complication that we had in the past. We want to reduce this as much as you can. And by, for example, having information about calcification in around the valve or in the LVOT, what is the height of the coronary arteries, or what is the size and calcification of the LVOT, all this information, or calcification in the aorta, all this information can help to reduce these complications. So I should say that the CT can help us with a lot of these parameters. So CT, there are many ways to do it, but I'm just going quickly. So what we do now is the last one, where we have the 256 slice CT. So what we do is we take the chest, which is gated. So it's important because at that time we want no motion at all. And we have to do it like in systole because the largest annulus of the aorta is during systole. Some people advocate to have retrospective gating, so all the cardiac phases and they measure, but that will have a huge amount of radiation. So we abandon that and we do it only in systole. Then the rest of the imaging will be non-gated because it's not important to have gating there. And then we can get some images like this with single contrast injection, a very low radiation, no breath hold, no heart rate control. We have beautiful images like this. And we can also convert this to a 3D where you can see all the 3D structure from the aortic annulus to the aortic root to the ascending aorta, descending aorta, and the access in the femoral arteries. Then again, then it becomes a bit time-consuming what to do and what to include in the report. And if you know, when you are working in the TAVI business for many years, you can appreciate that every year there are many other parameters added. So it's really becoming time-consuming, and it's good that if you don't do it manually, you do it through like a software or something, it's going to be a little bit fast, but still we have it manually because we don't have the software. So we have all these parameters that I will mention, we do it manually. But we became a bit fast because of the experience. So the first thing that we do usually, we calculate the calcium score because that has been correlated with two important outcomes. The first outcome is when there is a larger amount of calcium, the patient will not do well, even if he is treated or untreated. The other thing is calculating the calcium score might help us in some selected population where low flow, low gradient AS is the case. For example, and this has been already mentioned in the guidelines. So if you have discrepancy between the aortic valve gradient and the aortic valve area, meaning that the aortic valve area is small, but the gradient is low, which is low flow, low gradient AS, you can always go to the cardiac CT and measure the aortic valve calcification, the same way we measure the aortic coronary calcification. And then by guidelines, if the aortic valve calcification more than 2,000 for a male or 1,200 for a female, this has been associated with severe aortic stenosis. So this can help to refine some patients who are a little bit more difficult to assess aortic valve. The other thing is to see where is the distribution and the extent of calcification, because not all the calcification are the same. If the calcification is distributed evenly in the leaflets or in the extending to the annulus or extending to the LVT like here, it can also complicate the procedure and might change some of the decision to go into the depth or change the valve because of the risk of complication. For example, it has been associated with paravalvular leak or rupture of the annulus or even like the pacemaker insertion. And this is when for example, demonstration that with the presence of calcification in certain area can predict paravalvular leak. And this is the same, like the same information that if you have, for example, a valve commissure calcification, you know, there is always a risk for paravalvular leak. The other, what is important really, what is essential, and the CT maybe is the best imaging modality, is the assessment of the aortic annulus. And we knew that the aortic annulus is not anatomical, it's a virtual structure. And echo has been there to assess the aortic annulus. The problem with the echo is that it is only one or two planes that we can get, or multiple planes, but very limited. And it's good that we don't have calcification in this case, but if we have calcification, it becomes even impossible to assess the aortic annulus. While the CT, for example, not only the calcification is not a problem, but also we have unlimited projections. We can have multiple projections, and we have we can measure the aortic annulus in any projection. But what is even better than this, we can take the two orthogonal planes, means two parallel planes, and then we divide the image until we get the cross-sectional image of the annulus itself. And we do it like this. We go to the level of the sinus of Valsalva, and you can see the trileaflet there with calcification. And then we go down, 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 until we see the attachment side there, and then we go down. This is the attachment. And once the attachment is not there, this is the annulus. Then we measure the perimeter. We measure multiple diameters if you want, and we can measure the areas. And what is now important for the multiple companies, that they are following the perimeter and area. For example, one company will follow the perimeter, and again, with the perimeter, you can convert it to a mean diameter. For example, if you have a perimeter of 74 millimeter, you can just divide it by 3.14, which is a pi, and will give you the mean diameter. So the perimeter and the area becoming the standard for the imaging now before TAVI. The reason we have to have an accurate assessment, because we have multiple valves with multiple sizes, and we have to fit that size to that annulus without oversizing, without undersizing, because oversizing can rupture the annulus, and undersizing, like in this study here, if you have the valve which is smaller than the annulus, there is increased risk of paravalvular leak. So it is important, very, very important, to choose the size of the valve, which is provided by the company, to that right annulus there. So no other imaging technique that can give you an accurate assessment of the annulus other than CT. I mean, MRI is another competitor, but again, the CT is better. And using the CT compared to the echo, we can have a better assessment of the annulus, and we can reduce the chance of paravalvular leak, as you can see here in this study, without even increasing the chance of rupture. The other important, which is related all to the annulus, is to assess the valve morphology, whether it is bicuspid, like in this case, and bicuspid is different types, of course, with commissures, without commissures. So, for example, this is with commissure. And also, if we do retrospective, which we don't do now very often, we can also have cine images where you can see the structure of the valve while it is open and closing, like in this case here. But again, this causes a huge amount of radiation, so we don't do it. So this is trileaflet, this is bicuspid. Why it is important to assess the morphology? Because the morphology can be also a bit related to the annulus and also the whole root. It becomes a bit unusual morphology. So it can complicate the measurements, and we have to discuss it between us and intervention. Where to measure, what to measure, is it the annulus, is it the opening, is it, and again, when we measure, for example, as you will see in the next slide, when we measure the sinuses, we usually measure from commissure to sinus, but in the case of bicuspid aortic valve, there is no facing commissure to that sinus. So what to measure? I mean, it becomes a bit more complicated, and we have to reach to a conclusion what to measure. The most recent, I think, and they need more research about this, is the membrane septum length. And again, CT, as always, it is a very good imaging technique to see the membrane septum there. It's from the attachment to the muscular septum. And, the longer it is, the better. The shorter it is, some people, they say it is, some research say it's 3 millimeter, some reports say it is 5 millimeter. But again, the shorter is the more problematic, because the closer it is to the conduction system, and whenever you implement, deploy a valve there, it will just press on the conduction system and cause conduction disturbance and the need for permanent pacemaker. So then we can assess the rest of the aortic root. For example, we can assess the sinuses, because we need to have a large sinus so it can fit the valve without compromising the perfusion of the coronaries. Again, we have to assess the sinotubular junction and also the root height, because it's important to have not a shallow root, because shallow root also will compromise the perfusion of the coronaries. Is that, I think I...
Can I have one minute, please?
So I'm not going that fast, huh?
He will own it for you.
Yeah, okay. So this is the coronary heights. It has to be at least 10 millimeter. And the angle of deployment is, again, we need more refinement. And if we are, and there are two ways of doing this, either to make it 3 sinuses at the same line, or there is like a sinus overlap. But it is important if you have this software that can help you with this. Then we can assess the vascular access. It's very easy because now this is semi-automated, and we make 2 points, proximal and distal, and then we can have this iliofemoral axis, and we can see the size, because size is important to prevent complication. We can have a very nice axis like this, or very poor axis, and then we can provide summary images for the interventional cardiologist. So CT is clearly that provide important information, integral part in the intervention, and reduce the complication by following the CT measurements. Thank you.